Okay, hello everyone. So we have a video planned today. We're going to be covering a case sort of OSCE style. The plan is that we'll hopefully answer some of your matrix side questions, as well as sort of introducing you to what OSCEs are like this year. And I hope the start of your semester has been going okay and it's not too overwhelming just yet. So we're going to jump straight into it with this first case. So we have a 30-year-old AFAB presents to the ED saying, "I'm finding it's hard to breathe." She's able to complete the sentence, but it is difficult for her. She also volunteers that she has a cough. So there's going to be throughout this presentation a few slides like this with a big pause button. I really do want you to pause the video and have a go, maybe even just writing down on a piece of paper nearby, or if you need to say it aloud as well, have a go just doing that and answering some of these questions. Take as much time as you need and then come back and restart when you're ready. So hopefully you wrote down some differentials for what might be going on. I've just made here a pretty big list, to be honest, of all of the differentials for cough and shortness of breath. This is way too much for an OSCE, so don't feel like you have to get everything, and a lot of this is very irrelevant to the case. I've just written down essentially everything I can think of that is covered in third year relating to cough and shortness of breath. It's probably the first couple here until the anxiety section, which actually is probably relevant to the case. After this is getting into stuff that, might be affecting more older patients rather than a 30-year-old. So essentially just these first couple here. You'll notice I color-coded in blue, red, green, and yellow. That's just to show you that there are several systems that could be affected here. In an OSCE, try and get at least two systems. So, if someone's coming with shortness of breath, it's pretty obvious that it's something probably resp or cardio related. So definitely get those two out. Anxiety is a really easy one to sort of put in there, particularly with shortness of breath. And, nephrotic syndrome is something that's very random. You probably don't have to actually ask that. But, if you really want to show off that you can do four systems, you have nephrotic syndrome as an option. Now, you see here, I've written down a bunch of differentials, but also a lot of symptoms next to them. So, for example, our first one, PE, has swollen legs, syncope, and hemoptysis. What I'm trying to show you is essentially what's called clustering. In third year, the way you take histories is actually very different to how you've done it in the past, because in first year, second year, you just had a system review and you just had to essentially list off a bunch of different symptoms and then hopefully get a yes or no. Whereas in third year, we don't do that at all. Essentially, we have someone come in with a cough and shortness of breath. We might be thinking, oh, maybe they have a PE. So I'm going to ask all the questions, all the symptoms related to a PE. So I would ask this lady, do you have a swollen leg? Have you noticed, a red leg recently? Have you had any syncopal episodes recently? Have you been coughing up any blood? And once I've gotten sort of a response to that, maybe they're all negative, I go, okay, maybe it's less likely to be. It still could be. I'll jump to the next point that I have, which is pneumothorax. Then I'll ask, have you had any chest trauma recently? Is your chest pain? Do you have chest pain? So you sort of go through and you're screening each of these differentials with all the possible symptoms that they could be experiencing. At the moment, whilst you're still learning, I think it is good to write out a lot of these symptoms if you can. I think it's week 2 for you guys or something like that. So don't expect to know really anything so far. But it's good practice to do. And by the end, when you get to the end of the year, you probably won't even actually have to write down all the symptoms. You'll probably just know what's expected in a PE. I still found it quite useful to write out a differential list, just so, in the heat of the moment when I'm really stressed and panicking in the middle of an OSCE, I can always go back to my my little sheet of paper that I wrote down all these things during our 2-minute reading time and just remember, oh yeah, I forgot to ask about asthma. So this is a good way to sort of organize yourself in that 2 minutes. So we did a history, okay, and I'll tell you that she's had an episode of hemoptysis. She estimates that she coughed up about a tablespoon worth of blood just the one time. And you were a really good med student, and you really did clarify that it wasn't an episode of hematemesis, and it was actually a cough and not a vomit. So you're a really good med student. She's also had some pleuritic chest pain, and she's noticed a red swollen left leg in the past few days. So I'm going to be nice and sort of give you the diagnosis because I know it's a bit early on. I hope some of you may have started to think about a P. It's okay if you didn't, all right? I want you to stop and just write down some risk factors for a P. So I hope that you wrote some risk factors down. I have a whole list here. Now, the reason why I'm particularly sort of laboring this point is that in a history, if it sounds like a P, you really do actually need to explicitly ask for these risk factors, which you might not have been told to do in your respiratory systems review last year. So I would go through and I would ask this patient, are you on the pill? If so, what type of pill? Are you on progesterone only or a combined pill? Are you on hormone replacement therapy? I just run through all of these ones. So essentially in this patient, they're just taking birth control, okay? Otherwise, they don't really have any other risk factors. And this, I can't stress how important it is to actually ask all these risk factors in the history. Please don't forget. Write it down in your 2 minutes if you need. Okay, so this, I'm going to ask you to pause. I know some of you will not do this, but I really, really want you to. Just pause and maybe write down or say aloud, bully a parent or a sibling into doing a rest exam. Trust me, it's better to do it now whilst you're watching a YouTube video than to do it when a consultant asks you on the spot. So even if you don't remember anything and you just remember, the vital signs that you would take, just have a go. So hopefully you did do that, because otherwise I'll be very, very sad. So these are some of the abnormal exam findings that I listed it on the exam. So she's a bit tachycardic, she's tachypneic, she has a low oxygen saturation, 93%, a swollen left calf, and the lungs are pretty clear to auscultation. It's pretty important that you do know the normal ranges for a lot of the vital signs. So since it's the beginning of term, I'll be nice. Tachycardia is anything about 100 beats per minute plus. Tachypnea, if they're doing 20 breaths per minute, that's getting a bit excessive. Oxygen saturation obviously depends on their baseline. So if you have someone with COPD and they're chronically at 93%, you're not going to be too scared. We otherwise have a very healthy 30-year-old with no other past medical history. 93% is quite low. There should be at least 98% above on oxygen, on room air, sorry. So that's the exam findings. So now I want you to write down some investigations. A good way to break it up is to do what you do at the bedside, some bloods and some imaging you would do. So again, we're still sort of thinking P, and I'm going very P specific. But in your OSCE, you would still probably be thinking of other things. I've just already told you it's a P, but maybe she has a fever or something. Maybe you're still thinking pneumonia. You might want to do some other tests outside of these, but this is a very specific P. So at the bedside, if you haven't already done so in your rest exam, just mention vitals. Please never forget vitals. It's so, so important. Anyone with any shortness of breath or chest pain, just slap an ECG on. Please do that. For PE, for ECG, you'll hear a lot of people say this, S1, Q3, T3. I didn't know what that meant for the longest time, so I've kindly provided you with a little explanation and an ECG example. So essentially, there's just deep S waves in lead 1, there's a Q wave in lead 3, and an inverted T wave in lead 3 as well. It's a bit of like a buzzword, and everyone says that this is what happens in a PE. It's actually very uncommon and very rare. The most common finding on an ECG for PE is tachycardia. Almost everyone has tachycardia. You can also have like new right bundle branch blocks and right axis deviation, but that's not everyone will have that, and they're not going to expect you. No one's ever going to give you an ECG and an OSCE of just right axis deviation and expect you to get a P from that. Absolutely not. They'll probably give you either tachycardia or maybe this S1Q3 T3 pattern, but even then quite unlikely. That's just for fun knowledge. In terms of bloods, every OSCE patient will get an FBE UEC. That's just your opening statement. Get that in now. For a P or DVT in particular, you want to do a D-dimer. That's very controversial. I'm sure you'll get 20 different lectures from 20 different people about how much they love or hate D-dimers. I'm not getting into it. Essentially, a negative D-dimer means that you do not have a DVT or P. But a positive D-dimer means that you could have a PE-DVT, but it's not specific to it. Essentially, D-dimer looks for the presence of clots, and that can be any type of clot in the body, not specifically a PE. And so for that reason, if you have a positive result, you do kind of have to look for a P, but it doesn't specifically tell you it is that. You can also do an ABG. It shows you respiratory alkalosis. Have a think about why that is. That's good revision. And you would also maybe consider doing a coagulation screen, particularly in someone who hasn't actually really responded positively to any of the risk factors that we had earlier. It sort of seems like maybe an unprovoked DVT-P. In terms of imaging, it's really important to say CTPA, and that's very gold standard, and that will give you the diagnosis. Some people aren't able to tolerate a CTPA either because they're pregnant or their kidneys don't really work very well, and they get a VQ scan instead. Now, she's had a swollen leg as well. We're considering DVT, so you do a leg ultrasound. You can still do a chest x-ray just to rule out any other causes of any of these symptoms, because a chest x-ray should come back completely normal in a P. Now, I want you to pause and write down how you would manage this patient. Even if you just remember, give them oxygen or something, I don't care, just write something down. So I'm going to give you a bit of a framework in an OSCE of how to sort of answer this question, because you very well could get something like this. Always, 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 always start off by saying doctors ABCD. Doesn't matter what they have. They have a sore throat, I don't care, just say it. Particularly if you're on ED setting, just always say it. Like, I don't care what it is, just say it. And then say IV access. All right, and that covers your very acute sort of resus situation. And then you can also say, if they've come in with chest pain or shortness of breath, slap on an ECG, just do it. Then after I sort of covered my very initial basic management, I go, after a thorough history exam, vitals and investigations, and if they haven't asked me investigations specifically previously in another question, I might actually just say, particularly like a CTPA or a D-dimer, and under the assumption that this is a P or a DVT, I would do this, because that gives you a bit of a structure, because otherwise, they might not even have told you yet this is a P, and you're sort of just supposed to figure it out. So sort of just really set yourself up that you are actually answering specifically for a PE and you've covered, history exam, everything like that, because that really does help. I then break it up into short-term management. So what you can do for them, you're the intern on ED. What are you doing for them right now, right then, right? And then I want you to look at long-term management, because, this has been an unprovoked P. You're probably going to have to do something for them in the long term. You're not just going to send them home and be like, oh, you're fine now, bye-bye. And then risk factor management. This is particularly important for chronic conditions, even like ACS, for example. You'll probably want to at least touch on it if you have time. If you run out of time, that's fine. I think almost everyone runs out of time. You get like a minute or two to answer this question. So get to the important points. This is not as important. And then the last point is just make sure they have some long-term follow-up with someone. You don't want them to just disappear from the health system forever. And it seems sort of like, you're not just launching straight into, I would give this anticoagulant. You're actually setting yourself up for a very sort of thorough, very measured response to this question. And even though it might not be, everyone's obviously going to do doctors ABCD if they've collapsed, right? It seems very obvious to us. But in an OSCE, you really have to make really simple statements like this that will just set you above the rest of the other students sitting in the OSCE. Yeah, so launching into details now. PE management was very confusing, at least for me. Maybe you guys are all experts at this and you understand it. I found it really hard. And this is a huge disclaimer as well, that I might have gotten something wrong. So if someone tells you, this big dog consultant tells you something, listen to them, not me. But this is as simple as I can make it for myself. And hopefully this does give you, at least some understanding. And it's not just, you just anticoagulate them. I don't know what that really means. So after you've done doctor's ABCD, you can give them oxygen if they need to. So, if the oxygen saturation is dropping below 90%, you definitely want to consider oxygen. Otherwise, talk to a senior consultant that knows what they're doing in terms of oxygen. And then sometimes you might need to do a fluid resus and give some medications, but that's fifth year content, so don't worry about it for now. If they have a really, really severe PE, if you have to do like a resus, it'll be very obvious in an OSCE if it is a severe PE. They'll probably even tell you. You might consider giving them thrombolytics. So either alteplase or unfractionated heparin. almost all the time it's alteplase now, and it's used for, again, the treatment for PE and DVT is the exact same. There is no difference between them, apart from obviously not giving oxygen for someone who's just on the DVT. But yeah, most of the time you give them alteplase. The only time you give unfractionated heparin is if they have chronic kidney disease and if they're pregnant, because alteplase isn't particularly good for either of those conditions. So hopefully those text boxes, you can sort of read them in your own time, provide a little bit of information about which one's which, but essentially just go alteplase if they need it. Not every patient will need a thrombolytic. So if they have severe PE DVT. Oh, and important to mention as well with alteplase is that after using alteplase, this last point is it's important, but no one really mentions it. You have to switch to a low molecular weight heparin as well after using it. Yeah, just keep that in mind. No one's going to examine you on that, hopefully not. At least if they really mean, they will. But yeah, that's just something to know. So after you've sort of acutely managed the episode or the incident, you want to start them on anticoagulation. Okay, and there's 2 types of anticoagulants we can use. So we have NOACs and we have warfarin. So hopefully you have heard of these words at some point. Most patients get a NOAC, so either rivaroxaban or apixaban. We don't like to give them warfarin or dabigatran. The only time we don't give a NOAC is if they have chronic kidney disease, and that's a theme for all anticoagulants. If they have chronic kidney disease, NOACs are really bad for these patients. So in that case, you might need to give warfarin. The only important thing with warfarin that I really want you to remember, apart from like obviously bleeding risk with all anticoagulants, is that warfarin actually has the first couple of days on warfarin. It's actually really weird, and you have a pro-coagulative effect in that when you first start warfarin, the first couple of days, you're actually more likely to form a new blood clot, which is really strange. I don't understand why. If you know, please tell me. It's very odd. And because of that, you don't want to give them another PE. You actually have to give them other anticoagulants at the same time. And usually that is low molecular weight heparins again. I think they're on the next slide that I have that. Yes. So parental anticoagulants, they're low molecular weight heparins. Enoxaparin seems to be the most common one that I've ran into whilst I'm on the wards. So again, they're used with warfarin in the first couple of days when that's that funny side effect of that procoagulative stage. They're used after alteplase, so hopefully you remember that as well. They also seem to be used in pregnancy and in cancer patients as well. And a lot of people on the wards, especially if you're on gen med, most hospital patients are on some type of prophylaxis for PE, especially if they're there for more than a couple of days. And you'll see, the nurses will have like enoxaparin ward around, essentially, where they give everyone injections for this. That's really all the detail you need to know about that. And then we have something called an Ivc filter. It's not super important, I don't think, but it's worth just mentioning. Essentially, if someone's been anticoagulated and, they're doing all the right stuff, but unfortunately they're still having PEs and things like that, you might consider placing an Ivc filter. Essentially, it's this little device that goes into the inferior vena cava and literally stops the passage of a clot into the lungs, which is pretty good. The only thing important to sort of understand here is that anticoagulation is contraindicated. So, yeah, fun facts. In terms of how long you have to anticoagulate them, you have the difference between a provoked DVTP or an unprovoked DVTP. I did sort of say earlier that this is more likely, in the case that we've been doing, that's more likely to be unprovoked. Essentially, the difference between the two is, say someone who is pregnant or say someone who's just had surgery yesterday, that would be a provoked DVT or a PE, because there is something that happened that we can trace it back to, and then that caused the PE. Whereas an unprovoked DVT or PE, essentially that means that we can't really find anything that has caused it. They haven't had surgery, they haven't been on a long flight anywhere, they're not pregnant, they don't have cancer or anything like that. There's no real reason for it, and they've just had an unprovoked one. So it's really important to sort of have that distinction. So for an unprovoked DVT or a PE, both of those are indefinite lifelong anticoagulation. because obviously we don't want them having another P. For a provoked DVT, 3 months, and for a provoked P, it's about 6 months. That number can vary. It depends on the specialist treating the person, but these are usually the minimums that they're on, and this is quite important to know. So going back to our original case, we're going to put all that we just learned into context. So we have this lady, we've treated her doctor's ABCD, we have IV access, we've slapped an ECG on her. And then I would literally say, after doing a thorough history, exam, vitals, and investigations, some of the investigations I would consider as doing a D-dimer or a CTPA. And if the presumed diagnosis is in fact a PDVT, I would, in the short term, potentially give alteplase, followed with low molecular weight heparins and other resuscitation measures if it is indicated in the scenario and she does have a very severe acute DVT or a PE. After sort of stabilizing her condition, I would like to admit them to the ward and subsequently give them anticoagulation. In this case, I would consider a NOAC, such as rivaroxaban, if she doesn't have any kidney disease. In the long term, after she has gotten better, I would consider switching her oral contraceptive pill to a progesterone-only pill. Because estrogen there is some link between the estrogen and Ps. So in this case, I would like to change it to a progesterone-only pill. Whether or not that actually caused this PE, who knows? And I'm still considering this as an unprovoked PE. Thus, I would like to anticoagulate her indefinitely. I'd also definitely like to teach her anticoagulant safety, avoiding big bleeds or anything like that, and important to recognize the early symptoms and get prompt treatment if need be. I'd also like to do some risk factor management counselling. So letting her know that, things like long flights, sitting down for long periods of time can contribute to a PE, and the other risk factors as well. And I would really like her to be discharged and followed up long-term with her GP and come back if she has any symptoms such as shortness of breath, hemoptysis or chest pain. I'd like her to come back to the ED. That's sort of how I would summarize that management. You might get like a minute in your OSCE to do this. So don't feel, like it's the end of the world if you only got to the short-term management. Even if you get to that, that's great and you're doing really well. So I hope that was good. Let me know in terms of feedback how you found this video, whether it was actually useful, whether you would like it as a Zoom and for it to be more interactive. I don't care if you tell me you absolutely hated it and it was like the worst 10 minutes of your life. Please tell me. I'd rather know. I don't want to be doing these for no reason. So give me some feedback and let me know if there's any other conditions that you would really like covered. And as always, feel free to message any of us, either through Facebook, and we have a Google form this year as well for anonymous feedback. Good luck.